Yeah, thank you very much.
But,
sorry for the delay, so I have to start.
But maximize, please, if you can.
This is the maximum here from here.
Okay, that's fine.
Yeah. Sorry for the delay. It was technical. I'm not, as I said, I'm not very good with IT. So I'm talking about hypoxic respiratory failure in term and near-term infant. In fact, as my dear friend, Professor Sameh mentioned, the talk was originally on the precision medicine and use of omics in neonatal practice, which is what interests me now. But it's a lot of omics and metabolomics and genomics and things. But I thought, because this is actually just the finalized a few days ago, actually here was the guideline group in Scotland. So I thought to share it with the yourself in Egypt. This is Aberdeen now, where I work as a senior consultant here. So the temperature is 3. There was heavy snow few minutes ago, and the temperature, as you can see, is 2 to 3. So lucky you, actually, it is warm in Egypt. And this is Aberdeen, where I work. So it's the northeast of Scotland. And interestingly, there is a launching of the new hospital, which is that will be up and running in 2 years from now. And if anyone is interested, that may watch the space, because there will be some vacant jobs for maternity and neonatal unit. This one costs £230 million. It's worth to mention that yesterday I actually was impressed with the Luxor, the Sphinx Avenue ceremony. It was amazing, actually, and every Egyptian should be proud belonging to this country. So let's go back to the topic. So what is respiratory failure? It is the two things. We say oxygenation and ventilation. Oxygen is the failure of respiratory system to oxygenate, which we call hypoxemia, or failure of ventilation, which is hypercapnia or clear CO2, with one or more of three things. Either when the oxygen requirement is needed of nearly 60% or more to achieve a saturation in the range of 95, and when the CO2 is nearly, are you listening? Are you okay?
Yes.
Yeah. And the CO2 is nearly 8 kilopascal, which is 7.5. In UK, we use kilopascal, not millimeter mercury. So it is nearly 60. And when the pH is less than 7.22. So these are the criteria of the respiratory failure in a ventilated bed, either the non-invasive or invasive ventilated baby. So this is an example, actually. A few days ago, and still baby is here in the special care. The baby A, Singleton, was born in the District General Hospital, 41 weeks, weighing 4.66 kilos, spontaneous vaginal delivery, so thick meconium, pale apneic limb at birth, IBBV suction, but I cried after 5 minutes, Abgas with 1, 8, and 9. Commenced on mask CPAP with increased wake-up breathing and required 100% FiO2 to maintain the reductal saturation on admission was 90. And these are the code gas, pH 7.12, basic says -8, lactate is 5. And these are the series of X-rays that have been done. So this is the first X-ray with meconium aspiration syndrome, and the baby got pneumothorax, you can see, and then were intubated and got the 2 chest drains with pigtail chest drains. And you can see here that the things are getting even worse, because actually the baby already went into more progressive respiratory failure and went to an ECMO center, and they had ECMO. And you can see here, this is this tube in the aorta and this tube in the right atrium. So you got VA ECMO, which is venous arterial ECMO, and you got 2 chest drains. And then it's still the same And you can see it's very edematous and so, and it's because the muscle relaxed and it's sedated. And finally, that is getting better. That is in terms of the lung-wise, still intubated with 2 chest drains, and now is, I think, still intubated, but with right upper lap collapse consolidation with a little bit of lung infiltrate and the edematous because of muscle relaxants as well. So these are this baby is now in high flow. So this is how the condition progress in severity and how was managed here in Scotland. So this is the stepwise approach of term and near-term infants with hypoxic respiratory failure. And first of things is the principle of treatment. I try to make it as simple as possible. The one is to try to ventilation and consideration and to optimize lung recruitment. So if you're going to intubate, you need the right size. And generally, if I talk about terms, or 3 kilos is almost 3.5, and 3.5 kilos are in 4 to minimize any leak. The ventilatory settings have to be optimized, and we'll talk about what is the under recruitment and overextension later. If you are familiar with high frequency, you can use it. If there's any pneumothorax, the same as you can see in the BVS in the X-rays, you drain them and clear airway from obstruction and suction. Although it is repeated suction could be harmful, so be careful. May got worse with repeated suction, only when necessary. And surfactant if you think there is deficiency or inactivation. Second is the pulmonary vascular resistance to minimize and increase pulmonary flow, noiseless, no bright lights, improve the acid base, and the pulmonary vasodilator also talk about it. Then the circulatory, which is improve the cardiac function and systemic blood flow and pressure. So it's treat hypovolemia, inotropes so needed, the HB around 13, and the echo if someone to assess the function. Like if you got someone like Dr. Shergill, so he can help with make some decisions about the heart function. And finally, and reduce oxygen consumption by sedation, muscle relaxation, and normothermia. I would make it simple because always I remember is three things that is important. One, ventilation. Second, circulation. Three is the third one is selective pulmonary vasodilator. So remember, when you have progressive respiratory failure, is ventilation, circulation, support, and the pulmonary vasodilator. So let us start with the scenario. This, for example, the BVS baby we talked about is the term with the meconium aspiration, or did some resuscitation at birth and was admitted with CPAP and so. Then the required an oxygen of more than 60, CO2 is around 60 in the first hour or 2 of hours. What you are going to do? Remember this: ventilation, circulation, and others. So this is the respiratory thing, which is the ventilation thing. Ensure what thing? Adequate ventilation. So you use a tube and you start the right tube, no leak, and mechanical ventilation to start. But you have to avoid the collapse and over distension. A rule of thumb: the lung volume, when you look at the X-ray in the posterior ribs, how many posterior ribs? 6 to 8, not less than 6, not more than 8, and no flat diaphragm. And that is what you are achieving. No narrow heart on X-ray. So that's what you are achieving. Be sure that the pneumothorax to treat, and what is your target of the PCO2? It's 5 to 7. So 5 times 7 or 6 times 8, around 40. So it is around 40, of 40 to 45. Avoid atelectasis and keep the pH more than 7.2. And you try the pre-ductal, which is the right hand, please. Saturation is more than 94. so it is around 95. That is what you try first, ventilation. Anything you can do, yes. I wouldn't go into the vulnerable dilator now because of the surfactant. If you think that there is any evidence or deficiency or activation, and remember the DOPE, DOPE. If the baby is ventilated and deteriorated and require more oxygen, so remember, apart from the exclusion of the is 4 things: D for dislodgement of ET tube, O obstruction, pneumothorax equipment failure. This, remember the DOPE. Okay. Then cardiovascular, circulatory, optimize the volume. You first start with the bolus of the 0.9% sodium chloride. If you think there is anemia or so, you give back cells. What is your target blood pressure? Remember, easy. Mean blood pressure is above 40. I myself, I use the systolic pressure, which I target 50, and monitor urine output. Should you start inotropes to maintain it? You can, and that is. So what are the combination of inotropes you are using? Yesterday, I listened to a very good presentation of the BBHN by Professor Rania Higazi. It was great. She mentioned a combination of some inotropes. We do it differently. It doesn't mean this is better or this well, but this is what we do here. So you start with adrenaline at 0.03 to 0.05 microgram per kilo per minute, or dopamine 5 to 10 microgram per kilo per minute. It's important that we don't use both together. Why? Because of the tachycardia. Second, and we avoid dopamine dose as well, more than 10 microgram per kilo per minute. For tachycardia, risk of tachycardia, that will compromise the ventricular function. So you start with adrenaline, that is a start, or dopamine. This is as a start. You put the lines, USC and the UVC. The baby, we had you can see the UVC in, and they had a peripheral arterial line. Or instead of UVC, you can use the big line, which is the long line. Analgesia and sedation. We start usually with a morph, with a bolus of mic, 100. Then we followed by infusion. Depends, and this dose will be titrated according to the response. Muscle relaxant, it depends on what you use, pancuronium, bicuronium, muconium, or any of this, so long you understand how it works, is as an antibiologic muscle relaxant. And be sure, just that you need to know that there are some drugs, the muscle relaxant can cause hypotension, tachycardia, and hemodynamic instability. So you need to be aware of the side effects of the drug you are using. Sedation, we use midazolam in big babies, 50 to 100 microgram per kilo. Bolus followed by infusion of 60 to 100 microgram per kilo per hour, and also is saturated according to the response. That is, you may use it as to consider using. If you are in doubt about what you are treating, if it is lung, it is heart, it is pulmonary hypertension, thing, ask someone for echo. If you have someone who can do echo, as I said, if you have someone like Churchill, which I'm was around, I feel comfortable, so I ask him to come and help. So because I'm old-fashioned stuff. Although I know how to do echo actually for make decisions, but I don't commit myself. If congenital heart disease, if you think it is cyanotic heart, you start the prostaglandin 1. Why? To maintain ductal patency. To start at 5 up to 20 nanogram per kilo per minute. So there is no harm. If you think that the cardiac could be a cyanotic heart, not responding, so you see saturation. And there is a rule of thumb, I use it actually, it's not in the books, but this is what I use as a guide. If the saturation is less than FI2, you need to escalate treatment. This means if the saturation, for example, 80, and the baby is 100% all the time, regardless of what you do, you need help. You need help. So if saturation less than 952, simple to remember, you need to escalate the management. Then to monitor, of course, you need to bedside monitoring, and you do the pre and post. Pre, it is right hand, and then the post, the left hand or the leg. Then you ask for advice. So if you are level 2 and district hospital, you need to ask for help, actually for referral to some further advice from the referral unit. So after you tried everything at 2 hours and still the baby continued to need high oxygen requirement more than 60%, and you think that it's a severe lung disease or the baby is going in is suspicion of the hypoxic respiratory failure, this is what you do. You see how you escalate the treatment. Still ventilation, you'll be sure that you are giving adequate ventilation. As I said, it is over distension. I don't do ultrasound of the lung. Perhaps in this situation, ultrasound could be helpful, and it is not time consuming, and also not to upset the babies who may not handle very well. So there is a scope for using ultrasound. Okay? So just no atelectasis, no over distension. As I said, 6 to 8, no flattened diaphragm, and the heart is not small. Pneumothorax, the same thing. You aim CO2 5 to 7 kilopascal, around 40-55. The same. Avoid acidosis, pH 7.2 or more than 7.2, and saturation. Rather than we say more than 94, it is now you accept lower saturation, which is around 90. And remember, if you are going to use the arterial VO2, when the baby is in the womb, the VO2 in the umbilical vein is 4.7 kilopascal, which is nearly 35, I think, the millimeter mercury. So that is the least you can accept. That is so the baby need the saturation. If you are going to do VO2, it is around that normally in a preterm is around 6 to 8. In this baby, it's 7 to 12. So remember, it is around 6 to 10, which is 6 times 7.5. So you see what does it mean. So it is what you are target around this time. So remember the physiology, in fact, actually the fetal physiology and what you are target. Then you can use a specific bronchodilator like inhaled nitric. And the surfactant, consider if you think there's inactivation or deficiency, you use high frequency if you are familiar. And again, remember, deterioration, remember, baby ventilated, the DOP. Always remember that if a baby is ventilated and deteriorated, remember DOP, D-O-P-E. Dislodgement of ETT, ETT obstruction, pneumothorax equipment failure. It is always good to remember this at the economy. Then the circulation. We give another bolus, but avoid repeated boluses. Then with blood pressure, as we said, is a mean around the more than 40. I use systolic above 50 urine output, and the correct metabolic acidosis. And now you give adrenaline. So you're not waiting now. You have to support the circulation now, which is by giving adrenaline, and this is higher dose, which is 0.3 to 0.1 microgram per kilo per minute, or dopamine. Again, avoid tachycardia. More than 180 can compromise the heart function. Fluids, transfusion only to keep the hemoglobin around 13 or more, and a sort of hydrocortisone. These babies may not respond if that particular the inotropes, and there is maybe a relative adrenal insufficiency, so you can give the hydrocortisone as in a dose of repeated doses every 4 hours. And of course, you need to have an access, the UAC and UVC or PIC line. Sedation, the same we said, is a morphine and titrate accordingly, and muscle relax. Midazolam, and as I said before, be aware of the hypotensive effect of sedation and muscle relax. So because it can cause the hypotension, because of some of them have histamine-like effect and cause hypotension. Again, if you are in doubt and not responding, and if you have someone to do echo, that would be good. If still cyanosis and you think it's cyanotic heart, no harm with starting the prostaglandin E2 to maintain ductal patency, 5 to 20 nanogram per kilo per minute. Monitor the same bedside, be ductal, and the advanced monitoring that will be. Then again, if this is in level 2, so you want to escalate it more and send to another unit that you got more advanced the equipments, so like high frequency machine also, so that is you start as early as possible. So if it still continue to worsen, and what do you do? So you have oxygen requirement is high, CO2 is still high, oxygen requirement is still more than 60, but now it's 100% hypercapnic. So what you do is, now this is the full-blown management. So this is the whole management. Ventilatory, you try high frequency if you are familiar. If you avoid atelectasis and overextension. And once you put the baby on machine, on the ventilator, on the high frequency, they keep an eye on. So of course, you do an X-ray. In the past, we used to do X-ray every few hours, not anymore. But it's to be sure that the lung inflation is right. And the aim, the same thing, CO2 of 5 to 7 kilopascal, around 40, 50. Avoid acidosis and breathe duct saturation rather than 90 now, it is around 85. This is or more. So that is the preductal. It is the brain. So that is what you do. And you use specific pulmonary vasodilator, which inhale nitric. Consider, as I said, not responding. So this is a time when you consider more of DOP. I'll keep on saying it and repeating it because sometimes people forget it. And recently you have a case and people forget actually. They were all fixating on intubation, while the baby could have pneumothorax. Dislodgement, ETG obstruction, pneumothorax equivalent. I keep on repeating, sorry. Surfactant, if you think so, and important thing, left ventricular dysfunction could be considered if there is no response to nitric. Now, and cardiovascular, this is the same, blood pressure, remember numbers. Target blood pressure is mean of 40. You using adrenaline or dopamine, the hydrocortisone, the whole protocol. Use everything now. So this is the escalation to give everything. That is PEG cells if the hematocrit is low and correct metabolic acidosis. You can consider use of other cardiotropes like milrinone or dobutamine. We'll talk about this later, actually. And remember, don't increase the dose of the inotropic support. You have to think about it. Why? You can lead reduced cardiac output because of the increased tachycardia and may cause vasoconstriction. Also, we don't use the combination of dopamine and vitamin for doses more than 10 because of the chronotropic effect. Tachycardia, avoid tachycardia. And the lines, as I said before, you need to have an axis, USC and central line for inotrope. Sedation the same, morphine, midazolam, and muscle relaxant. Again, you run out of ideas, cyanosis, you think you're congenital heart, no one to scan, there is no harm to start prostaglandin E2, that is to exclude to allow. There is no harm. That is could be cyanotic heart and ductal dependent lesion. And that is the monitor, as always, you monitor sick bay. Is this baby require ECMO? That is the. So there are two issues here. A, we say the pulmonary vasodilator and this inhaled nitric. And inhaled nitric, this is standard care of any baby with hypoxic respiratory failure, like in cases like PBHN. I know in Egypt, the inhaled nitric is not available, as I understand. Is it right, Dr. Samah?
It is right. Unfortunately, it is not available.
Yeah. So the inhaled nitric, I remember it started. I was in John Radcliffe Hospital in Oxford, 1990, doing the training. During this time, we have the first case of a child, 5 years, who got the pulmonary hemosiderosis and respiratory failure and was in PICU and required the first baby child to be on nitric. And that was inhaling nitric from a cylinder. That was was on archives. That was the first one. Since 1992, it started actually neonates and becomes now standard care. So it is a standard care, which is need to be reconsider it. So if you don't have nitric, which is what you do, there are some other modalities of care. Phosphodiesterase inhibitors, you use sildenafil. Also, it's reported, and perhaps you have, it is used in Egypt, I understand, where it is used in centers where nitric is not available. It prevents rebound pulmonary hypertension as well. People are using magnesium sulfate as well in refractory cases. Prostacyclin can be used as well. And tolazolene. Tolazolene was in the era before nitrate, which is not used anymore because it can cause severe hypertension. So, and renal problems. So that I used actually tolazolene long time ago is more than 30 years. So that is, I'm not sure whether it's available or not anymore, but it is not available anymore here. Then ECMO, extracorporeal membrane oxygenation, is another thing, because this is the last resort of hypoxic respiratory failure in irreversible lung disease. Reversible lung disease. So it is. Is there any pediatric ECMO center in Egypt, Dr. Sam?
For neonate, no.
No. The interesting, actually, the first one I remember of ECMO in neonates was by a guy, which is what's his name, Rupert Bartlett, right? Yes. This guy is called the father of ECMO, and they started in 1982. And in annals of surgery, there is a cohort of 100 neonates were treated with ECMO. 100. That is in annals in 1986. It was until 1995 that is the ECMO was only used for situation when there is the success rate of other modality is less than 10%. So you use this as the last resort, which not anymore. Here in Scotland, we have the ECMO center in Glasgow, because there's only one ECMO center, and the criteria for babies to go to ECMO in terms of gestational age and weight is is more than 34 weeks, because of the risk of the ventricular bleed in IVH in babies less than that, and weight is 2 kilos because of the putting catheters, putting tubes and going into the internal jugular esophageal or the aorta if it is going to the arterial. But now they have the experience of cannulating babies 1,800 grams or less. It's interesting, actually. So things are improving, to be honest. And meconium aspiration, it is a good success because the success rate is more than 90%. So this is the ECMO. So there is a scope of actually people thinking of ECMO in Egypt, although because it is used in adults. Yeah, there are ECMO centers I know in some universities, in ancient universities, for example, Castle they got ECMO for the respiratory failure for different causes, like the COVID, for example. Anyhow, so this is, then we'll go for other things. In the past, that is, the people are using alkaloids. And because some babies actually, the pulmonary vascular bed is responsive to the pH. So sometimes you establish critical pH. So you try to make the pH around 7.45 or even 7.46. Sometimes. If there is improvement in the VO2, so we call these babies our pH. There is no improvement, unresponsive, so stop. How we are going to use it? Hyperventilation we used to do is try to avoid. It causes harm rather than benefit. So people sometimes use the small bolus of bicarb or continuous infusion. But the problem of it, if you use it liberally, can result in hypernatremia and hypokalemia. So if you are desperate, so you can use alkalosis as the old-fashioned stuff, but avoid hyperventilation. So how you monitor the hypoxic respiratory failure? Oxygen saturation, you can see the trend, histogram over time, and there's a bedside monitor. And you range above 95 and between 95 to 85. And you're trying to avoid hypoxia. For even term babies got oxidative stress and got problems then. And I heard from Professor Rani yesterday in her presentation about the giving too much oxygen, which is true, because of even can affect the endogenous endogenous nitric oxide release. Yeah, I agree. AA ratio, alveolar arterial ratio, and give you an idea, and this is how you to calculate it. What normally is close to each other, of course, around 5 or so, and that is how you calculate the AA ratio. That is the, and if no impediment to diffusion. Oxygenation index you do, the oxygen saturation index and how you do it. And sometimes people, particularly ICU, we don't tend to do NEOS. Some units are using NEOS for regional saturation. Yes, the brain, gut, and so neo-infrared spectroscopy if available. So this is, will tell you how you assess, and all you look at the trend rather than, and if you target, and this is moderate and severe. I need to hurry, so I will go to the management of systemic hypertension, and that is mechanism, and what drugs are using here in systemic hypertension is left ventricular dysfunction, which is a common and usual transient, and how you treat and improve the cardiac function, and this is a drug of choice in here, not necessarily in Egypt, but actually we usually start with adrenaline or dopamine. That is what we use. Then if the left ventricular filling or preload and the decrease the pulmonary blood flow or hypovolemia, this is what your target or therapeutic principle, decrease pulmonary the resistance, vascular resistance, and improve the intra vascular volume, and by using pulmonary vasodilator therapies and volume. Then systemic vasodilatation is another mechanism, decrease diastolic pressure, clinical finding, and that's happening in septic shock, for example. And therapeutic is to improve the vasoconstriction. So no adrenaline has a role here, and or vasopressin. I occasionally use vasopressin in septic shock, and that is be cautious in left ventricular dysfunction. These are all the drugs are used. That is all the inotropes or the lusitropic drugs that works on the diastolic function, like melanon, and that is the goal in BBHN. Just as simple to remember, the increased systemic vascular resistance decrease pulmonary vascular resistance, and optimize heart. And it can tell you if which drug is best in different situations. Then goals of pulmonary hypertension, adequate pulmonary flow, as I said, is by increasing systemic vascular resistance, decrease pulmonary vascular resistance, and optimize the heart function, both inotropes, lusitropes, which is systolic or diastolic, and excessive myocardial, the oxygen consumption. And it is important in some situation which is refractory. This is the guys I know from Australia. I work with the Nick Evans and colleagues. So they started to use some time ago is the to maintain ductal patency as a pop-off valve for right ventricle when the right ventricle is function, and that's what they use. So perhaps I stop here because of too much information and I ran out of time. Simple thing to remember, that is treatment of the hypoxic respiratory failure. Remember three things: ventilation, circulation, selective pulmonary valve dilator. If we don't have nitric, don't worry. Think of other measures. We mentioned about the drugs, that is including sildenafil. We talked about other drugs like the prostacyclin and others. And we talked about alkalosis and things for short term, avoid the hyperventilation. And remember, I always use this one. If saturation, oxygen saturation, less than FiO2, treatment should be escalated. So, and may ask for help and referral. Thank you for your listening. I hope you find it helpful. And if you have any question, you can email me on this as my email address, and I will be very happy to answer any questions. And also, I'll be happy to share PDF of this guidelines to anyone who wants to apply in practice. Thank you very much, and thanks, Dr. Sameh, for your time. Thank you.
Thank you very much, Dr. Medhat, for your excellent presentation. But can I ask a question now? Or?
Yeah, sure. You go ahead.
Okay. Is sildenafil oral as equivalent as sildenafil IV in managing pulmonary hypertension?
We use yes. It is. I think it is more or less have the same biological effect. Yeah. Well, is it right, Shevjil?
Sorry, but sildenafil, not yet. Not yet. I haven't tried it.
No.
I actually, from our experience here, yes, we use both.
So you use both? Okay. No, I mean, is oral sildenafil as equivalent as IV sildenafil?
My understanding is yes.
Yes,
but I need to check, because actually we occasionally use it, but because we have inhaled nitric, so we don't use sildenafil too much here. In fact, only when you wean off inhaled nitric and you still have pulmonary hypertension, you give it. But you start with IV, but you continue with oral, so you can use oral. I think it's the effect more or less the same. But I will check. I'll let you know.
Okay.
So, Dr. Ezzat, I've seen this being used in the ECMO center in Glasgow, Queen Elizabeth. So when the baby can tolerate somewhat orally, go on oral with the same dose. And
yes, it's what I know. Yes, it's the effect, the biological phase is the same. I feel so it can be used oral. Yes.
Okay.
Can I ask a question?
Yes, go ahead.
I'll be quick.
You ask me, Shevjil.
I'm asking you.
Yes.
So, my question is that normothermia, it's important to maintain this, we all understand. A term baby, severe meconium aspiration syndrome leading to PPH and all that, there can be HIE, and you may choose to, maybe need it to be therapeutically cooled. So if you're cooling a baby alongside managing the hypoxic respiratory failure, does the management change in any way? Is there any difference in somebody who's not?
Yes, I can answer it. So it's a very good question. Remember, actually, from the oxygen dissociation curve, when you have the low temperature, the shift of the curve to the left, right? So if you have refractory hypoxemia, the answer is yes, you may stop. But if you have still you can manage the pulmonary hypertension and you maintain the saturation, which is pre-ductal, around 85 mark or so, you continue, because you are talking about irreversible damage to the brain. Something is reversible. So there is a compromise. So refractory hypoxemia, yeah. But if it's pulmonary hypertension in itself, and you can maintain the pre-duct saturation around 85 or so, the answer is to continue cooling. Yes, as the new protected. Yeah.
Okay, thank you.
It's the oxygen dissociation curve, so you know that it will be on the shift to the left, and will cause problems. Yeah. Yeah.
Dr. Medhat,
there can be a situation where I may have to back off with cooling. So
yes, there is. Yeah, if it is, as I said, refractory hypoxemia, and the as I said, the BO2, which is in umbilical vein, is the umbilical vein is 4.7. So you need to be above that. So if you reach 4.7, it's extremely hypoxemic. So you cannot. So don't accept. This is a factor. Yeah.
Great. Thank you.
Right.
Dr. Medhat,
yeah.
As you know, actually echocardiography in most of our neonatal units in Egypt are not always available, and it's not done by the neonatologist.
Yeah.
So if the neonatologist or senior researchers in charge are working, are suspicious of pulmonary hypertension,
yeah.
What are the empirical lines we can start till an echo is done or till specific management is done?
But remember, ventilation, circulation, pulmonary dilation. So you start with optimized ventilation. That is the first thing. We need to optimize ventilation. So if, for example, before we go into anything, so if, for example, if on CPAP and still a little oxygen, 60, 70 thing, and the BO2 is still low, and that's so you need to intubate, and that's to have to optimize the ventilation. So optimal ventilation, recruitment of the air, of the lung, and use sedation, or occasionally plus or minus the muscle relaxant, and be careful about muscle relaxant can drop the blood pressure. So that is to start with. That the first thing is the circulation. As I said, blood pressure, mean blood pressure, you need to have an axis. Yeah, blood pressure, mean blood pressure around 40. I use systolic of 50. So blood pressure around 40. So that is target. If, as you heard, maybe need to be normothermic. So temperature, yeah. If there is no sign, no HIE as mentioned. So the no hypoxic encephalopathy. So yeah, so baby should be normothermic, and volume-wise, that is and normal volemic, and it's not anemic. So that is that's what you do first. So it's lung first, and support the circulation. Yeah, that's what you do before you're doing anything. Perhaps you start from simple things, and you escalate if there's no response.
Okay, I have a question from Bashar Al-Qaisi. Management of peristaloma with paralysis and hypocalcemia due to difficult labor and cord wrapped around fetus.
So which one of? So he asked. Thank you for the question first. So
he is not. He doesn't specify either Ahmed or Medhat. So
no, it's not. Either of us can answer.
Oh,
I'm
okay.
saying what?
Can I? Do you want me to ask it the question again?
Yeah, because it is someone who got the difficulty with labor, right?
Okay. No,
all around the neck.
Management of peristaloma,
yeah,
with paralysis and hypocalcemia due to difficult labor and cord wrapped around the fetus. It is around the neck.
So I'm not sure actually which way you're going to manage. Sorry for this, because someone who got trouble at birth, right? Is the baby got any signs of the HIE? I'm not sure. It's so got birth asphyxia. So you treat birth asphyxia. If you are, if the baby is clinically well and there's that neurologically there's no signs of encephalopathy, fine. In terms of traumatic delivery and is having the bruising, right?
Yeah.
Of is it affecting the function of the fusion? That depends on the clinical assessment. We're going to assess hypocalcemia. How bad is hypocalcemia? I don't treat hypocalcemia, to be honest, until it's very low. That is myself, because they always improve with time. That is so except in certain situations, in fact, but generally, if your nice calcium is one or more, so I don't treat. So if it is far low, yes, I may start thinking of treatment, because I don't rush on and treat. That is, and maybe maybe 5 years, I had never treated one case of hypocalcemia. Actually, for this scenario, I wait until things improve. That is, so it depends in how symptomatic all of this are. Is the baby got birth asphyxia need treated as HIE? If the confusion or the bruising is affecting the function, limb function, the fusion also, is the hypocalcemia is symptomatic enough, and how low is to be treated? That is so yeah, and that's so it depends on a clinical assessment, as surgeons would said when they use the ultrasound. You clinical assessment and how the baby they show any signs of symptoms, actually, then this can guide you on treatment, or you can adopt what we call, to me, I call WWW, wait, watch, and wonder, rather than to be proactive. That is which is wishful waiting, and that's what I do in many situations. Sorry, I may not answer this question, because the wishful waiting is not always helpful, but this is what I do.
Okay. I have another question from Andres. I don't know where is he from, but he said, good day. In case of right failure, I don't know what does he mean by right failure.
Right ventricular failure.
Okay. And yeah. I understand, but it is not, he doesn't mention, and it is not possible to use melarinon. The use of nitric oxide is an indication regardless of the oxygenation index.
They use nitrogen.
Nitric oxide.
NO, inhaled nitric oxide, yes.
Inhaled nitric oxide is an indication regardless of the oxygenation index.
Yeah.
And if it is, how would you handle this?
Let's start with inhaled nitric, because as I said, inhaled nitric has been from the 1992 they started and becomes standard care in pulmonary hypertension or hypoxic respiratory failure. So you do the start. And the majority of the cases will respond, maybe 1 in 3, sometimes may not respond. And the effect, it is from 2 to 6 seconds, actually, you have an effect. The half-life of it's 2 to 6 seconds. So So if nitric, inhaled nitric is available in scenario of this scenario, I stop. Yes, so there is no. People don't, as I said, I use the saturation and FI2. If the saturation is going down and we use more of FI2 and you think it is not the cyanotic heart, so I stop nitric, especially if there's some underlying background that indicates that the pulmonary hypertension, like the meconium aspiration, for example. So you start. So there is no harm of starting inhaled nitric, and for half an hour, if no response, you stop. And if there is a difference between the pre-duct and post-duct is more than 5 saturation, you start. So no harm of starting. So I agree. I don't use any, even in ECMO as well. People have been the oxygenation index, they don't use it for ECMO. They'll say more than 30 or something like that. I think if there is escalation of the all treatment it fail, you go for ECMO as well, because especially meconium aspiration, the outcome is very high. That is in terms of survival. So yeah, you use the oxygenation index as a guidance, not a strict guidance, not a protocol. So yes, I agree with it. So that's it. I agree with inhaled nitric without using the oxygenation index in a ventilated baby. Yes, if other things fail, that's fine, and you can start from the beginning as well. The first question is right ventricular failure and the use of the milrinone, right?
Yes.
We use milrinone because it has both effects. It has even the inotropic and lucitropic effect. That is so you can, and it has to be used with cautious, particularly in babies with the HIE. That is important because actually when you have an HIE, there is decrease in its metabolism, renal, and which can build up and cause accumulation in the body, leading to more side effects. So I think it's to be careful about using milrinone. Yeah.
Okay, thank you very much.
And in fact, people are using actually when they wean off from the nitric because of the phosphodiesterase inhibitor effect. Yeah, but I'm saying is need to be careful about actually when using it. It has because of in situation when we have HIE or so and this accumulation of the side of the drug and its side effect.
Okay, thank you very much indeed. I know you are traveling to Cairo tonight or early
yes,
morning.
I'm off to Cairo tomorrow. Yes.
I understand.
Yes.
Thank you very much. Yes, looking forward to seeing you. Thank you very much. Dr. Ahmed, inshallah, we'll meet again either online or physical to learn more about the ultrasound modalities you did in the UK. Thank you very much indeed.
I would be looking forward to it, Professor Tawfiq. It has been an honor, and yes, I would be looking forward to see you and to more opportunity to speak on your forum. Thank you very much again.
Thank you very much.
Thank you very much. I hope it was fun and educational. Thank you very much.
Thank you very much indeed. Thank you. Thank you very much. Thank you very much. Karim. بلغهم يعني اديني بعد اذن حضراتكم، يعني العصر فاضل عليه 10 دقائق، انا هصلي العصر وانا المهندس كريم وهنرجع لكم بالظبط 10 minutes ان شاء الله. Thank you very much.